Okay, in this presentation, I want to go through a little bit of review for neuroanatomy as it applies to physical therapy practice and talk through some of the structures of our lovely nervous system, but also some of the functions and try to link it to a few clinical applications or clinical presentations that we might be thinking of or might see in physical therapy. So for this neuroanatomy review, goals for the presentation are to review basic terms and organization of the nervous system, review the relevant neuroanatomy of the brainstem, and cranial nerves, spinal cord, cerebellum and basal ganglia briefly, and major sensory and motor tracts. We also want to link each of these areas with clinical relevance for the physical therapist in neurologic practice or in assessing neurologic issues or potential deficits. So when we're thinking about the nervous system, I think it's useful to really have a great understanding of some of these terms and some of these basic structures that we're going to be talking about a lot. And if we do this, then I think everything else that we build on top of that is going to be benefited to a great degree. So just as the great basketball player Michael Jordan said, get the fundamentals down and the level of everything that you do will rise. And so that's why I really try to emphasize in neuroanatomy the understanding of and discussion of these basic fundamentals that are going to help inform everything else that we try to layer on top of it. So I really want you to think about what are the differences between the central nervous system and the peripheral nervous system. What do those two terms refer to? What is a ganglion versus what is a nucleus? What is a nerve versus what is a tract? What is a cranial nerve versus a peripheral nerve? So as we'll see, there's some similarities between those two and there are some differences. What is an upper motor neuron and what is a lower motor neuron? Starting off, simple discussion of the basic unit of the nervous system. So smallest unit of organization within the nervous system is a nerve cell. And this we refer to as a neuron. So neuron has nerve cell bodies, which is going to be the gray matter that we see. And there are also axons, and that's where the signals are going to be transmitted between neurons. So between neurons and also between the cells that neurons communicate with. So whether that's muscle or another effector organ or sensory organ, those axons are going to be the communication in between those two cells. So axons are going to be white matter, and they're going to show up as white commonly because of the myelin or the fatty covering around the axon. Not all axons are myelinated, but we're going to see those show up on imaging or gross dissections as white matter. So some basic terminology of the nervous system. These the nerve cell bodies are going to be gray matter. In the central nervous system, which when we refer to the central nervous system, we're thinking about the brain and spinal cord. The peripheral nervous system, we're thinking about everything that exits or the peripheral nerves or nervous tissue, anything more distal to the spinal cord. So we're thinking about peripheral nerves, dorsal root ganglia and alpha motor neurons, and all of our peripheral nerves, nerve roots. Those are all peripheral nervous system. So nerve cell bodies within the central nervous system we call nuclei or a nucleus. And an example of this within the central nervous system, within our basal nuclei, would be the caudate nucleus. So that's going to be part of the deep gray matter in the central nervous system. In the peripheral nervous system, we call collections of nerve cell bodies, we call them ganglia. And my best example for this is one structure that we should be pretty commonly familiar with, and those are the dorsal root ganglia, or those are the collections of nerve cell bodies within the peripheral nervous system, but within the periphery that contain nerve cell bodies for our sensory nerves. So that's going to be the first neuron or the first sensory nerve in our main sensory tracts. So we're going to see those DRGs show up as we talk about tracts a little bit later on. And those collections of cell bodies we talk about as ganglia. So that's where that term comes from. As far as collections of axons, so again, white matter or these you can think of them as maybe wires or connections of that nerve cell. These are going to show up as white matter, but they're going to have different terms in the central nervous system versus peripheral. In the central nervous system, we call these collections of axons tracts or columns. So in the spinal cord, we see tracts or these collections of axons. If you think about the dorsal column, if you think about the spinothalamic tract, if you think about the anterolateral system or anterolateral system is a synonym for spinothalamic tract, so that's not a great example, but spinothalamic tract or dorsal column, I think, are going to give you a sense for the white matter in the central nervous system. In the peripheral nervous system, we simply refer to groups of axons as nerves. So that term gets thrown around a ton, but I think if we step back for a second and really try to think about what that means, it's going to have a little bit more significance for us, and we're going to be able to think about it and talk about it in a little bit more intelligent way. So nerves really are these collections of axons within the peripheral nervous system. So keep that in mind as we discuss nerves. And remember that cranial nerves are peripheral nerves. So cranial nerves are peripheral nerves that exit the brainstem, versus peripheral nerves are going to exit the spinal cord. Cranial nerves are going to exit from the brainstem. So they're still peripheral nerves, though. They still could have a motor function, a sensory function, or both, and they're going to be within the peripheral nervous system by definition. So what is the central nervous system versus peripheral? Talked about this just a little bit. Central nervous system is going to incorporate the brain and spinal cord. It's going to include upper motor neurons. So as we're talking about a motor neuron, what we're really discussing is the two neuron chain of the corticospinal tract, or the nerves that supply motor innervation to the face. But really, if we're thinking about the two neuron chain, it's most simply described as upper motor neuron and lower motor neuron to the upper extremity and lower extremity. So I'm going to try to keep it simple, and that's really what I'm referring to. So that upper motor neuron, or the first neuron in the two neuron chain for our corticospinal tract, is going to be coming from a pyramidal cell in the cortex. And so it's going to be part of the central nervous system, because that cortex of the brain is where it lives. That's where that cell body lives, and then it's going to send its axon down. So central nervous system is made of these structures, including these upper motor neurons, which are so incredibly important to our motor function and the movements that we assess as physical therapists. In the peripheral nervous system, this part of our nervous system, or this division of our nervous system, is going to include the peripheral nerves, as I was talking about. It's going to include nerve roots as they exit the spinal cord. I'm circling here, nerve roots, which are going to be mixed sensory motor. And those nerve roots are going to have contributions from both the dorsal root ganglia, or sensory contribution, where information is coming from the periphery into the spinal cord and up towards the brain. It's also going to have motor contributions from these alpha motor neurons, which are sending motor information down to the muscles. So this second neuron chain in our corticospinal tract is going to be a lower motor neuron, and that is going to be part of our peripheral nervous system. So we can see here, this is just a picture of the lumbosacral plexus showing some of those peripheral nerves or peripheral nervous system. All right. So what are nerve roots? Well, these spinal nerve roots are going to be mixed nerves, or mixed roots coming from different levels of the spinal cord. And we know that these nerve roots are going to exit between the vertebral bodies, and we're going to have 31 of these total. So 8 cervical, 12 in the thoracic area, 5 lumbar, 5 sacral, and 1 coccygeal. And we also know that for spinal nerve roots C1 through C7, those are going to exit above the vertebral body of reference. But then, because we only have 7 cervical vertebrae, that C8 nerve root is going to exit below C7 vertebral body. And so that's going to start the trend that then follows for the rest of these spinal nerve roots, where the nerve root is going to exit below the vertebral body of interest as we drop below this C7 vertebral body. So that's kind of the pattern as those exit. And what are we thinking about when we think about central nervous system disorders? So we've made this distinction between central nervous system and peripheral nervous system. So central nervous system has to do with the brain and spinal cord. What are some dysfunctions or disorders that we might commonly see in those parts of the nervous system? So we're thinking about brain disorders and spinal cord disorders. So brain dysfunction or brain disorders, and I'm sorry about the acronyms, but it just makes for a little bit cleaner slide. So CVA, or cerebrovascular accident, commonly known as stroke, that's going to be a brain injury, traumatic brain injury, acquired brain injury, spinal cord injury. All of these things are going to be injuries or are going to present with deficits of the central nervous system. Brain or spinal cord tumors could be another thing. MS, multiple sclerosis, which is a central nervous system myelin disorder, progressively demyelinating disorder, as it were. And so depending on the area where that disease is manifest, is going to depend on the deficits that you see, but it could be in multiple areas of the brain. So cortex, cerebellum, brainstem. And then let's contrast that with some examples of peripheral nervous system disorders or lesions. So the peripheral nervous system, again, we talked about being made up of everything distal or towards the periphery from the spinal cord. So our peripheral nerves, our nerve roots. What are going to be some examples of lesions or disorders that affect that part of the nervous system? Okay, so we're thinking about peripheral neuropathy or disorders with peripheral nerves where you have maybe sensory deficits, maybe motor deficits, maybe both. Carpal tunnel. So carpal tunnel syndrome is compression of the median nerve, which is one of our main peripheral nerves that supplies motor and sensory information to our upper extremity. Sciatica, or irritation of the sciatic nerve, could cause radiculopathy within our within the lower extremity, buttocks, leg, sometimes down to the foot. Guillain-Barré syndrome. So that's going to be an issue with peripheral nerves. Polio or post-polio, that's going to be an issue with alpha motor neurons. Commonly affects the lower motor neurons. So I have that right there. Charcot-Marie tooth, it's going to be peripheral neuropathy, commonly affecting common peroneal nerve, although it can affect others. That's one of the most common presentations. And so really seeing effects from that nerve, lower extremity weakness, foot drop, could be manifestations from that disorder. So these are some pictorial representations of those issues that we were talking about. So a meningioma or tumor of the meninges in the brain could cause central nervous system dysfunction. Peripheral nervous system, we're thinking about, could be a dermatomal or myotomal deficit, in which case we're thinking a nerve root has been affected. Here's that lumbosacral plexus again. Or it could be something affected that is the entire peripheral nerve or one peripheral nerve. So those are some things to think about. And then back to our discussion of terminology and how important the foundations and fundamentals are to build up our understanding of the nervous system. So differentiating between a ganglion, which is a collection of nerve cell body in the peripheral nervous system. So here is, again, this dorsal root ganglia, or this group of cell bodies that supplies sensory information, innervation to our nervous system. So sensory data from the periphery is being taken up towards the brain. Versus central nervous system, collection of nerve cell bodies, we're going to call a nucleus. So gray matter in the central nervous system, collection of nerve cell bodies, these are these nuclei. So we can see the thalamus, which is collection of cell bodies. We can see some of these deep gray matter structures. So putamen, caudate, nuclei, although sometimes called the basal ganglia, which is confusing. They're technically nuclei because they're nerve cell bodies within the nerve cell bodies within the central nervous system, within the brain, deep gray matter structures of the brain. So like I said, it can be confusing. Here's a depiction of the basal ganglia, where you have the putamen, caudate, thalamus, amygdala even. So these deep gray matter structures are nerve cell bodies in the brain, colloquially or just in certain sources that you read. More often than not, they're called basal ganglia, but the correct term I would suggest would be nuclei, and that really focuses to differentiate between central nervous system and peripheral nervous system. So don't get confused by that, but that really is our terminology. So we talked about generally central nervous system dysfunction and peripheral nervous system dysfunction, but let's think a little bit more specifically about what dysfunction or what deficits we might see if there is dysfunction of these basal ganglia or these deep gray matter structures in the cortex. So what we're thinking about is the functions of these basal ganglia are to influence movement, influence the turning on and off of these motor systems, or kind of the coordination of movement. So they're not the direct circuitry of movement, that's our corticospinal tract, or the direct motor commands, that's our corticospinal tract, but they do help to facilitate the either turning on activation or turning off inhibition of different groups of muscles so that we can coordinate movement. So anytime we have movement, we have to have activation of the agonist muscle groups, but we also have to have inhibition of the muscle groups that perform the opposite action. Otherwise, we're just going to have this co-contraction and we're going to be like frozen or rigid. So these deep gray matter structures are going to help with that coordination, almost as if, I've heard this beautiful analogy, almost as if they are helping to lead the orchestra or conduct the orchestra in really bringing about these beautiful movement patterns that we're able to create as humans. So again, if there's dysfunction at these areas, we can see either a paucity of movement or lack of movement, and that can manifest as hypokinetic or lack of movement, or we can have an overactive system where they're hyperkinetic movement disorders. So these are going to be a few examples of these are going to be the diagnoses listed in this charts below. So hyperkinetic movement disorders are going to be things such as Huntington's disease, hemiballismus, athetosis, chorea, where you have an overactivity of some of these circuits. Or you can contrast that with hypokinetic movement disorders, such as Parkinson's disease, where you have akinesia, bradykinesia, and some of these characteristics or hallmark symptoms of Parkinson's disease due to dysfunction of the dopaminergic circuit within the basal ganglia, specifically the substantia nigra, but can be manifest within those direct and indirect pathway circuits that coordinate movement. All right, and as I differentiated above, we want to, again, think about what are these different structures of white matter within the peripheral nervous system versus central nervous system. So a nerve, which are axons in the periphery, or white matter in the periphery, that's going to be part of the peripheral nervous system. So we see right here a depiction of nerves of the upper extremity, versus in the central nervous system, these collections of axons, white matter, are going to be called tracts or columns. And so we can see the tracts along the neural axis in this picture. We can also see tracts within the brain, so with tracts either being projection or hemispheric or longitudinal. So we can have different tracts or fibers that communicate between areas of the cortex that are right within areas of the cortex or right next to each other. Sorry, I'm trying to represent these U fibers that are really small here, or between different areas of the cortex, or from cortical areas down towards other areas of the neural axis, and those would be projection fibers or tracts. Differentiating between cranial nerves and peripheral nerves, like I mentioned prior, cranial nerves are peripheral nerves that exit from the brainstem. Caveat to this is that cranial nerves 1 and 2 emerge from the brain, so those are kind of special sensory nerves, and because of their maybe older nature, actually emerge from brain tissue itself instead of brain stem. And so we can see that within cranial nerve 1, olfactory, and 2, optic, are going to be exceptions to the rule. So, however, the other 10 cranial nerves are going to exit from the brainstem, parts of the brainstem. They can have motor function, sensory function, or both. They can be mixed, just like peripheral nerves can be. So peripheral nerves are going to carry information from an effector organ to the spinal cord, or spinal cord to the effector organ, depending on whether it's a motor nerve, a sensory nerve, or it's going both ways. And they're going to emerge from the spinal cord. So those are our spinal nerves, with contributions from the spinal nerve roots that we saw in that one picture. So 31 spinal nerve root levels, and different nerves are going to have contributions from different nerve roots. Usually more than one, sometimes just one. And again, peripheral nerves can have motor function, sensory function, or both. So groups of axons in the peripheral nervous system, white matter, those are nerves. A little bit of cranial nerve review. I don't want to piece through this in a lot of detail, but it's kind of here for your reference. So the 12 cranial nerves, these are them named, and they're going to have different functions. So they're going to have different functions based on whether they are motor nerves, so they have communication to muscles, whether they're sensory nerves, they have communication from some sort of organ and pick up sensory data that they're going to send to the brain, or they have both. And because we know that motor innervation, but also sensory data, can be either from skeletal muscles or voluntary muscles, or it can be from organs or viscera, we have this kind of four options for these different nerves. So somatic is going to refer to voluntary or skeletal muscles, soma, body, so it's going to be from muscle, skin, joint, I would include in that, versus visceral is going to be from organs or viscera. And efferent is going to refer to a motor function. Afferent is going to refer to a sensory function. So you can either have motor to the body or motor to an organ. So you can have somatic, afferent, or efferent. You can have, you can have motor from body or organ, which motor is always going to be efferent. So somatic efferent or visceral efferent. Or you can have afferent information or sensory information from an organ or from muscle. And so sensory information from muscle or sensory information from an organ. And those are going to make up the 4 different options or components of these different cranial nerves. So depending on the cranial nerve, it's going to have different functions. There are functional groupings that can help you remember these, and so I've kind of laid those out for you to help out. So special sensory nerves are going to be cranial nerves 1, 2, and 8. The cranial nerves that are responsible for voluntary eye movements are going to be this group, 3, 4, 6. And then autonomic nervous system functions are going to be 3, 7, 9, and 10. Pure motor cranial nerves are going to be 11 and 12. So those are some good groupings to help you kind of chunk that information, remember it as a group, versus memorizing each one individually. Obviously, it's nice to know what each one does, but these kind of help facilitate if you can think about them as groups or as teams. I think that's easier to remember. All right, so let's talk about a little bit in more detail. What is an upper motor neuron versus a lower motor neuron? So we know we have this 2-neuron chain with the main motor tract is going to be the corticospinal tract. So we're going to have an upper motor neuron, but also a lower motor neuron. So the upper motor neuron is going to be that nerve cell body living in the brain, living in the cortex, and it's going to send this axon down to the spinal cord level of exit, and it's going to synapse on this lower motor neuron, which is our alpha motor neuron. And that lower motor neuron is going to have its nerve cell body live in the spinal cord, but it's going to be part of that peripheral nervous system. So upper motor neuron in the brain, lower motor neuron, cell body lives in the spinal cord. So it makes sense. The other thing that I don't want to fail to mention, and I think I mentioned this prior, but I didn't name the tract, is going to be the corticobulbar tract. So corticospinal tract is going to supply motor innervation to our upper extremity and lower extremity, so our arms and legs. But our corticobulbar tract is going to supply motor innervation to our face and tongue, muscles of the pharynx and larynx, to the degree that they are voluntary, or the voluntary muscles of those areas. And so that tract, or that motor, the components of that motor tract, are still going to have an upper motor neuron and a lower motor neuron, but that first nerve cell body is going to live in the cortex, just like we saw in the corticospinal tract. That second one, instead of being in the spinal cord, it's going to exit from the brainstem, and so that's what we call it bulbar. It's going to have to do with the functions of the face, of the head, neck area, and so it's going to be exiting or component of cranial nerve, versus corticospinal tract is going to be spinal nerve in the periphery. So here is another picture, because I think pictures really help, of the neural axis. So we have brain and spinal cord. That is our central nervous system, our upper motor neuron. So cell body sends its axon down, and then it's going to synapse on the lower motor neuron here in the spinal cord. So lower motor neuron, peripheral nervous system, and that alpha motor neuron is going to send its axon to the effector organ. So we see this skeletal muscle, and that's how we get information or command from the brain to the muscle, so that the muscle contracts. And that's going to be a really, really fundamental building block of movement. So here we see central nervous system is made up of brain and spinal cord, upper motor neurons. Peripheral nervous system is made up of peripheral nerves, nerve roots, DRGs, which are sensory, remember, and then lower motor neurons, which are motor contribution. So this is a little chart for you for your reference. I don't want to go through this in a lot of detail, but this is comparing upper motor neuron lesions with lower motor neuron lesions. And so they're different presentations based on where in the nervous system we have deficits or we have dysfunction. The analogy I really like to use is that of a child and a parent. And so if you think of the parent as the upper motor neuron, and you think of the child as a lower motor neuron, I think it helps to explain these deficits. So if you have a parent who's there, but the kid is dysfunctional, then what you end up with is the kid has a lot of energy, but the kid's no longer there. The parent gets to take a nap. The parent's kind of sleepy. And so the kid, or the lower motor neuron, has dysfunction. What you're going to see is you're going to see hyporeflexic, flaccid, severe atrophy. So the kid, there's a problem with the kid, the lower motor neuron. The parent's all good. The parent's like, oh man, I'm going to take a nap. So what you see is sleepiness, hyporeflexic, flaccid, severe atrophy, fasciculations, versus kid is pretty hyper. Kid, all they want to do is go out and play. That's just the natural state of a healthy kid, the lower motor neuron. Upper motor neuron is on vacation, checked out, injured, sick. Well, that lower motor neuron is going to take over. If the lower motor neuron takes over, the kid takes over, it's like pizza time all the time, climbing up on chairs, bouncing on the bed. So that's where you're going to see all of these hyper or overactive issues, is where upper motor neuron is out for the count. So injury to upper motor neuron is going to manifest as hyperreflexia. You're going to have increase in spasticity. You're still going to have weakness, but you're going to have potentially pathological reflexes, high tone. So hyperactivity, I think, is the key there. That kind of goes along with that analogy. And then you can kind of take a look at these discussions of how weakness manifests, how atrophy manifests, and then examples of dysfunction or upper motor neuron diagnoses versus lower motor neuron. And I think those will make sense a little bit. So upper motor neuron versus lower motor neuron diagnoses. Again, I had those listed a little bit in that prior slide. I think we've talked about these, but these are kind of for your reference. And let's start talking about a little bit of organization so we can get to the main motor tracts. Well, we talked about the main motor tract, corticospinal tract, but let's talk about some of the main sensory tracts within the nervous system. And as we do that, or before we do that, I want to mention this organizational principle that really holds true as we talk about the different parts of the neural axis. And when I say the neural axis, what I really mean is from brain to brainstem to spinal cord, so all the way up and down the nervous system, we have this similar principle of organization. And I love this because I think it helps us remember the organization, and it helps us really keep in mind where these neurons and where these tracts, where these nerves go and where they live. And it's a really nice organization. So what I tend to think of is the same in the back door, out the front. And what I mean by that is that sensory information tends to come in the back door, or it tends to, the structures that provide sensory innervation tend to be posterior. And that holds true in the brain, holds true in the brainstem, and also in the spinal cord. So if we see the dorsal root ganglia or the posterior root ganglia, that's sensory information. So that's coming in the back door. Versus motor innervation or nervous system communication to muscles goes out the front. So anything to muscles or anything having to do with motor tends to be in the anterior, tends to be in the front of this organization. And we can see that at all these different levels. So in the spinal cord, motor communication happens from this alpha motor neuron, and that's in that anterior, that's from the anterior horn cell, or the front part of the nervous system out. So in the back door, sensory information comes in, out the front, we're going out the front. So it happens spinal cord, brainstem, brain. That's also how our organization is set up in the thalamus, which we'll see in the next slide. But in the brain, most simply, we can think about what is our primary sensory cortex. Well, it's going to be our post-central gyrus. So the gyrus right behind the central sulcus. So again, in the back door, sensory data, primary sensory cortex, versus our primary motor cortex in the brain is going to be in that pre-central gyrus, or the gyrus, the gray matter, right, or the gray and white matter, the fold right in front of or anterior to the central sulcus. So primary motor cortex is going to be out the front. So I love this. The organization really holds true. And this is another picture that really describes in the back door, so sensory information coming in that DRG to that dorsal horn out the front. So motor information coming out the front, and this is that anterior horn cell that lives in the front or the anterior side of the spinal cord. In the thalamus, same thing holds true. So main thalamic sensory nuclei are going to be posterior. Main thalamic motor nuclei are going to be anterior. So I have that in the notes for you. I'm not going to walk through that because I think that gets a little bit detailed, but the organization is the same. So that's for your reference. Okay, so main sensory tracts. How do we get, or what types of information do we get coming in the back door? Well, we have two main sensory tracts that I want to talk about. First of which is DCML, or the dorsal column medial lemniscus. This sensory tract is going to have 3 neurons in the chain, similar to the second sensory tract we're going to talk about. And those 3 neurons, the first one's going to be the dorsal root ganglion. The second one is going to be a neuron from the medial lemniscus. And the third neuron is going to be from the thalamus to the cortex. So that's why we have 3 neurons in the chain versus our corticospinal tract. We talked about 2 neurons, is because we have this sensory relay system, or this place, this location that functions as a sensory relay within the nervous system, and that's going to be the thalamus. So the majority, I'm not going to say all because there are exceptions, but the majority of our sensory data as it comes into our central nervous system passes through the thalamus. And like we saw, that thalamus is going to be gray matter, and so it's going to have nerve cell bodies in it. And so as it functions as that relay, it's going to add an extra neuron to the chain. So hopefully that makes sense. So first neuron in this system, dorsal column medial lemniscus, is going to be this dorsal root ganglia. That the axon from that neuron is going to travel through the dorsal column. Again, we said column in the spinal cord is going to be column or tract that's going to be a group of axons in the central nervous system. And it's going to travel up into the brainstem, and in particular the medulla, and then it's going to cross over from right side to left side or left side to right as it synapses in that area, either at the cuneate or the gracile nucleus. And again, nucleus, collection of nerve cell bodies. As it synapses at that nucleus, that second order neuron, the axons from that are going to be contained in what we call the medial lemniscus as it passes through the brainstem, and then it's going to synapse in the thalamus. So that thalamus is going to be the third neuron in the chain. And that tract is going to communicate dorsal column, medial lemniscus, proprioception and vibration, sensory information, but also light touch. Our second main sensory tract is going to communicate, it's going to be the ALS, anterior lateral system, also called the spinal thalamic tract. So those terms are interchangeable. Anterior lateral system tells you where it's located in the spinal cord as it travels up. And this system is going to communicate nociception, or the inputs that contribute to maybe a potential pain response in the brain. But remember, pain is an output, so pain is not a sensory input, it's an output, so we call it nociception, as it's detected as sensory information, because that sensory information could be temperature information, pressure, chemical inputs, crude touch, and that's what's going to be communicated on this anterior lateral system or spinal thalamic tract. So first neuron in the 3-neuron chain is going to be this dorsal root ganglia. It's going to send information up the spinal cord, but before it does that, it's actually going to cross at the level of entry. So it's a little bit different than the DCML or dorsal column medial lemniscus, which crosses in the brainstem. This ALS tract is going to decussate, or it's going to cross over sides from right to left or left to right at the level of entry. And then that axon is going to, so it's going to synapse at the level of entry, and then it's going to travel up to the thalamus again, where we pick up the third neuron in the chain, which is going to send sensory information to the cortex, depending on which area it's coming from. And you see this sensory homunculus. So that's the representation of body areas based on cortical real estate. Okay, so main motor tracts, we talked in length about these. The corticospinal tract sending motor information to our arms and legs, corticobulbar tract sending motor information to our eyes, larynx, pharynx, face, and it's a 2-neuron chain made up of an upper motor neuron and a lower motor neuron. And again, it's information out the front, so those are going to be, it's going to be coming from that precentral gyrus down into the spinal cord. Where's it going to synapse? In the front, so anterior of the spinal cord, those alpha motor neurons, anterior horn cells. So what may we see if we have deficits, spinal cord lesions? Well, it depends on what tracts are affected. So in anterior cord syndrome, the tracts that run in this anterior part of the spinal cord are going to be affected. Posterior cord syndrome, posterior cord is going to be preferentially affected. And you can think about our little trick here. So in the back door, if it's posterior cord, we're going to have more motor or sensory deficits. Well, more sensory deficits. Out the front, anterior cord syndrome, more motor. Central cord, you can think about the tracts that are more centrally located. Brown-Séquard syndrome is a condition where you have one hemisphere or one side of the spinal cord in which the lesion is. Excuse me. And so you can think about what deficits are there based on where those tracts cross. So that I will let you review on your own, but just some things to think about based on what we know about the neuroanatomy and where those structures are. A few more things here to cover, and then I want to chat a little bit about sensory transmission, hoping we get to that. So with the brainstem and cranial nerves, if we see dysfunction in this area, what we're thinking broadly is that the brainstem and cranial nerves are going to support more of our automatic functions. And so signs and symptoms of brainstem dysfunction are going to tend to be these signs that we group as 5 Ds and 3 Ns. So diplopia, dysarthria, dysphagia, drop attacks and dizziness, and then numbness, stagnance, and nausea. So those signs and symptoms are going to clue us in that we may have a brainstem disorder or brainstem dysfunction. Some of our basic functions, so ability to eat, swallow, see clearly, GI functions or digestive functions. And so here those are, 5 Ds and 3 Ns spelled out for you. Cerebellum, cerebellar functions. So cerebellum is going to be intimately related with eye movements, vestibular function based on where it is. So balance, coordination, but it's also going to help us with motor planning and motor learning. And so dysfunction of the cerebellum is going to be manifest with dysfunctions in any of these areas, which a normally functioning cerebellum will take care of. So you could have balance or vestibular dysfunctions, you could have eye movement dysfunction, but one of the things that's going to be really common is that you're going to see dysfunctions in coordination. So discoordination in multiple areas. So ataxia, discoordination of gait, dysdiadochokinesia, or the inability to perform rapid alternating movements. And you're going to also see, probably, most likely, impaired motor learning, the ability to improve on motor skills or pick up on novel motor skills. Impaired coordination, I already mentioned, could have impaired cognition because of the cerebrocerebellum, or the part of the cerebellum that affects cognitive function. Could have impaired speech or language or vestibular functions, including potentially vestibulo-ocular reflex. So clinical tests for the cerebellum, you could assess different things in relation to vestibulo or oculomotor function. So some peripheral vestibular tests versus more central vestibular tests are going to help you rule in or rule out cerebellar dysfunction. Balance and coordination tests are going to help you assess cerebellar function or dysfunction, depending on what you're seeing as a lesion or presentation. So I know that's pretty quick, but again, this is just kind of trying to be really foundational with these constructs so that you can build off of these as you get into more nuances of clinical assessment. And when we're thinking about the brain, we also want to think about different functional areas. So different parts of the cortex are going to be assigned. Even though this isn't perfect, it helps us form an understanding for dysfunction, especially if we have brain injury. So for example, a stroke. Well, what deficits do we see, or what area of the brain is affected, and then what deficits might we predict? What areas might we want to train to reduce deficits or bring about the best function that we can. So if we're thinking about senses or sensory data coming from the body to the brain, we're thinking about different areas that correspond with or provide function within these different sensory modalities, if you will. So touch or proprioception, nociception, smell, hearing, vision, taste, so special senses. And then we're also thinking about cortical areas that correspond with motor control or muscle function. So the primary motor cortex, talked about that a lot. So the precentral gyrus, going to the alpha motor neuron. So this is in the periphery, so brain traveling to body. And these areas, just like our sensory, our somatosensation, are organized in what's called a homunculus, or cortical areas assigned to different body areas. So homunculus, the little man. So you'll see this picture, like we saw in that prior slide, of face, arm, trunk, leg, foot, and different areas of the cortex. If we stimulate those, or if they're active, are going to turn on or relate to different body areas, whether sensory or motor. So something to think about. All right, so when we think about sensation as it travels in the back door, as it travels from the periphery to the brain, and even when it travels within the brain, I like to think about the idea of it comes in as raw data and then it gets processed, versus motor information traveling from the brain out to the periphery is almost the opposite. So when I think about sensory areas in the brain, in the back door, What I think about is if you're feeling a sensation, 1, 2, 3, I see. So the idea being that sensory information is first going to come into the primary sensory cortex or a primary sensory area. So 1, it's going to move to a secondary association area where we start processing that data or making sense of it, integrating maybe one type of sensory data with another type of sensory data. And then it's going to get further processed in a tertiary area or sensory integration where we have maybe processing of 2 types of sensory data, but also an evaluative component. What does that sensory data mean before we start to make a decision on that, or before we start to integrate that into a future motor plan? So if you're feeling a sensation, if you have information coming into a sensory area, first it's going to come into the primary sensory area, and then it's going to go into the secondary area, and then third. So feeling a sensation, 1, 2, 3, I see. An example of this might be sensory data or touch data, so somatosensation, where first is going to enter the primary sensory cortex or the post-central gyrus. It's going to go to a secondary association area, the parietal lobe, and then a tertiary sensory area where that sense is integrated so that we can utilize that data. So this is true for touch, temperature, pressure, somatosensation, or nociception, which we know nociception could include chemical data, pressure data, temperature data. And these sensory areas that have to do with special senses have specific real estate as well, or specific areas and tracks that they travel down. So one of the cranial nerves that we talked about above that enters, is the exception, it doesn't enter in the brainstem, is going to be this olfactory, cranial nerve 1, olfactory nerve. And it's going to send its information first to the uncus in the limbic lobe where that primary olfactory cortex is. For hearing or for auditory information, first is going to travel in on that cranial nerve 8, so vestibulocochlear nerve, or the cochlear component. The vestibular component is going to be more vestibular or balance functions. It's going to travel into the primary auditory cortex or the transverse temporal gyrus before being integrated or before going to a secondary association area. So that's kind of where that information is going to enter. So again, we have our peripheral component, even though it's a cranial nerve, it's a peripheral nerve traveling into the first place in the brain or the first place in the central nervous system that information enters, and then it's going to be successively carried through and processed. But that's kind of the start of that, where that sensory information comes in. For vision, we have our optic tract. And again, this is an exception. So this cranial nerve is not going to travel into the brainstem. This is going to be via cranial nerve 2, optic nerve. So from the optic tract, chiasm, which just means the decussation of right and left optic nerve of optic tracts. And then after the chiasm, you're going to become the optic nerves and travel to the occipital lobe, which is going to be the primary visual cortex. For taste information, we have 2 cranial nerves that are responsible for taste. You're going to have sensation on the tongue, and they're going to travel to the insula, which is this deep cortex, almost looks like a fist within the 2 hemispheres, right and left. And that cortical area is going to be our primary gustatory cortex. For motor areas, we're thinking about out the front. So when I think about motor processing within the cortex, my little saying is going to be, if you're starting an action, it will be 3, 2, 1, go. So this motor information is going to start in the planning phase. It's going to start in a tertiary area with all of these inputs. It's going to travel to a secondary motor area where that motor plan is getting more distilled. And then finally, it's going to travel to the primary motor cortex, which we know is going to be the beginning for this corticospinal tract and is going to contain cell bodies of those upper motor neurons. So in that primary motor cortex, this is really going to be the initiation of a motor action or muscle instruction. And so from that upper motor neuron, from that nerve cell body in the primary motor cortex, it's going to travel down the axon in the spinal cord to a lower motor neuron, which cell body is going to live in that anterior horn cell. So it's going to be our alpha motor neuron, our lower motor neuron, or now we're in the peripheral nervous system. And that axon is going to travel to the muscles, where it's going to send the signal or the motor plan so that we can initiate muscle contraction or inhibition, as it were, and initiate some sort of movement or muscle action. So that's kind of a quick and dirty review of neuroanatomy, some of the organization of our nervous system. And I really hope that you took away from that a little bit of a better understanding of these foundational building blocks. It's obviously a very complex system, and so this is just a little bit to get you going and hopefully review a little bit if you've already had neuroanatomy, or give you a little bit of a primer as you're getting into neuroanatomy, give you a sense for how these things are organized, some of the basic terms of the nervous system, some of the basic principles, so that you can build off of this and really take this with you as you work through some of the increasingly complex layers and facets of it, as you think through these principles in your clinical practice or in assessing patient cases in neurologic physical therapy. So if you have questions, please let me know. I will post a link at the bottom of this recording to this PowerPoint so you have access to these slides. And I do want to leave you with this quote from prominent neurologist and really brilliant thinker and writer and doctor. And this is from Oliver Sacks, and he says, "The brain is more than an assemblage of autonomous modules, each crucial for a specific mental function. Every one of these functionally specialized areas must interact with dozens or hundreds of others, their total integration creating something like a vastly complicated orchestra with thousands of instruments, an orchestra that conducts itself with an ever-changing score and repertoire." And so there is this beauty and this appreciation that he is trying to communicate for the intricacy and the really profound manifestations of this nervous system. As I mentioned prior, just some of the beautiful ways that we are able to move in our lives, and with a functioning nervous system, it is just, I think, a remarkable thing that all of these things are happening, many of them without our conscious decision making or conscious control. So just kind of want to leave you with that for an appreciation for all of this really amazing circuitry and organization. And then a few references for where I got some of this information and the pictures